Hello and welcome back to my YouTube channel. Today's video will be on multiple myeloma or plasma cell dyscrasia. So let's get started. Multiple myeloma is one of the plasma cell dyscrasias. It is characterized by neoplastic proliferation of a single plasma cell clone which produces monoclonal antibody. The risk factors for multiple myeloma are age over 65 years, male are more likely to develop myeloma than females, black people are twice as likely to develop myeloma than white people, exposure to radiation and obesity and some plasma cell disorders like monoclonal gammopathy of undetermined significance, solitary plasmacytoma, and spontaneous myeloma, etc., can lead to multiple myeloma. Coming to the pathogenesis of multiple myeloma. The myeloma cells directly support osteoclast formation and inhibits osteoblast differentiation by releasing numerous cytokines. For example, interleukin-6, interleukin-7, interleukin-1, beta from myeloma cells and bone marrow fibroblasts and macrophages activate the rank ligand and stimulates the osteoclast precursor to form osteoclast. Myeloma cells also secrete inhibitors of osteoblast differentiation, DKK1. Osteoprotogerin secreted by the bone marrow stromal cells inhibit osteoclast. In multiple myeloma, osteoprotogerin is inhibited, which leads to stimulation of osteoclast and resorption of bone and formation of lytic lesions. Dysregulation of cyclin D, chromosomal abnormalities, etc., thus causes promotion of osteoclast formation and inhibition of osteoblast differentiation and lead to the resorption of bone in multiple myeloma. Due to monoclonal expansion of plasma cells, there is overproduction of one antibody abnormally. This leads to decreased humoral immunity and increased risk of infections, especially by Staphylococcus aureus, E. coli, etc. Now, what is M component? M component is actually paraproteins and are intact immunoglobulins or fragments of heavy or light chains. The most common is IgG kappa in the M component. In multiple myeloma, generally the serum M component is more than 3 gram per dl. Coming to the signs and symptoms of multiple myeloma. The patients of multiple myeloma generally present with bone pains, pathological fracture, nausea, loss of appetite, fatigue, frequent infections, and weight loss. Hypercalcemia, renal impairment, anemia, and involvement of bone are four very characteristic features of multiple myeloma, and it can be memorized by the mnemonic CRAB. C for hypercalcemia, R for renal impairment, A for anemia, and B for bone involvement. Coming to the lab findings in the cases of patients with multiple myeloma. The patients with multiple myeloma will have low hemoglobin. That is because of marrow replacement and renal damage causing loss of erythropoietin. The marrow replacement by neoplastic cells and renal damage causing loss of erythropoietin leads to this reduction in hemoglobin and corresponding anemia. The peripheral smear of these patients because of increased immunoglobulins will show formation of rouleaux. The ESR is also increased in such patients because of rouleaux formation. And because of extensive skeletal destruction, there is presence of hypercalcemia. The bone marrow aspirate of these patients show increased number of plasma cells, usually more than 30%. Also, various types of other cells which are actually the plasma cells differentiation. For example, Mott cells, flame cells, Dutcher bodies, Russell bodies, plasmablasts are also seen in patients with multiple myeloma. To elaborate, the Mott cell, grape cell, or morula cell are blue-white cytoplasmic droplets in the plasma cell and has been shown here in the image. The flame cell, when the plasma cell cytoplasm show irregular borders and give a fiery red appearance, it appears as flame, and then these modified plasma cells are known as flame cells. Dutcher bodies are actually the intranuclear inclusions which can be seen in the image here. Russell bodies on H&E section will be seen as eosinophilic inclusions in the plasma cell. The most common marker in immunohistochemistry used for detection of plasma cell or myeloma cell is CD138. Further in the diagnostic workup, X-ray, CT scan, MRI or PET scan can be done for detection of lytic lesions, which generally involve the axial skeleton. As you can see here in the image, punched out lesions in and radiolucent areas in skull, giving rise to the typical raindrop skull appearance. Also in the long bone, I have shown round punched out lesions as radiolucent areas in this image. Serum protein electrophoresis is done for confirmation in cases of multiple myeloma, in which, because of exposure to electric current, the proteins move according to their charges and various proteins create separate bands on the gel. For example, if you can see in the image shown above, you can see that in a typical serum protein electrophoresis, albumin, alpha 1, alpha 2, beta, and gamma show a graph like this, and the band appearance is shown in the A section. In cases of multiple myeloma, because of increased number of abnormal immunoglobulins, a M spike is seen, which you can see in the image below. Immunofixation is done for the subtyping of type of antibody abnormally produced in cases of multiple myeloma. IgG, IgA, IgM, which one? Benzstone protein urea is commonly observed in cases of multiple myeloma. It is seen in around 50 to 60% of cases of multiple myeloma patients. Benzstone's protein is a monoclonal globulin protein or immunoglobulin light chain found in and produced by the neoplastic plasma cells in patients of multiple myeloma. It can be detected by heat coagulation test. We heat the urine in a test tube at room temperature. There is no precipitation around 40 to 60 degrees Celsius. The proteins precipitate in the urine, which on further boiling the urine up at around 100 degrees Celsius, the precipitate dissolves, and when further cooled and the temperature comes between 40 to 60 degrees Celsius, again the precipitation is shown in urine, and at room temperature there is no precipitation in urine. This is a simple test for the detection of Bence-Jones protein in urine. However, nowadays this is detected by immunofixation electrophoresis. According to the International Myeloma Working Group, the criteria for diagnosis of multiple myeloma include clonal bone marrow plasma cells more than 10% or biopsy proven bony or extramedullary plasmacytoma, and any one or more of the CRAF features and myeloma defining events. The CRAF features include hypercalcemia with a serum calcium level more than 1 mgdl higher than the upper limit of normal or more than 11 milligram per dl, creatinine clearance less than 40 ml per minute or serum creatinine level more than 2 mg per dl, anemia with a hemoglobin value of less than 10 gram per dl or more than 2 gram per dl below the lowest limit of normal, presence of one or more osteolytic lesions on skeletal radiography, CT or PET scan. Also, presence of myeloma defining events are included in the diagnostic criteria now, and any one or more of the myeloma defining events can help in making the diagnosis of multiple myeloma. These myeloma defining events are 60% or greater clonal plasma cells on bone marrow examination, serum involved upon uninvolved free light chain ratio of 100 or more, provided that the absolute level of involved light chain is at least 100 mg per L or 100 mg per liter, and more than one focal lesion on MRI that is at least 5 or more in size. Coming to the treatment part of multiple myeloma. It's treatable but generally incurable, and the treatment options are chemotherapy, targeted therapy, immunotherapy, steroids, and stem cell transplant. The median survival in cases of multiple myeloma is generally 4 to 7 years. Translocations involving cyclin D1, translocation 6 is to 14, translocation 11 is to 14 are good cytogenic prognostic markers. And deletion 13q, deletion 17p, and translocation 4 is to 14 hypodiploidy are bad prognostic markers. So I hope you all understood this topic well. If you guys want me to make videos on your suggested topic, you can mention it in the comment section below. Also, don't forget to subscribe the channel if you're liking my videos. Thank you and bye for now.